Okay, I think we will go ahead and get started. Welcome to our webinar today, COVID-19 Pandemic in Focus. Just a couple housekeeping items. One, this webinar will be recorded, and anybody that was not able to attend today will have that assigned in Health Streams. Please make sure, I think I have everybody muted right now, but you do have the ability to unmute yourself. Be mindful of that and try to keep yourself muted. We will be taking questions throughout the presentation. If you have a question that you would like to ask, please put that in the chat feature, and I will keep track of those, and we'll have a question and answer session at the end today. Also, if you have questions that you would like to address more privately, Dr. Shaeffer, both of them, are willing to address those for us as well. If you are in the nursing field and you're wanting CEUs for this, you do need to be present for the entire presentation today. I am taking attendance for that. And then after this presentation, like I said, there'll be a HealthStream assignment for anybody that was not able to come and participate live with us today. So at this time, I would like to introduce you to our presenter today, Dr. Meghan Shaeffer. Dr. Schaeffer has a bachelor's degree in microbiology and a master's in public health and epidemiology from University of Iowa. She also obtained her master's of public administration from Drake University in 2013 and her doctorate of education and administrative leadership from Drake University in 2015. She worked in county and state level public health for 11 years as a disease prevention specialist, epidemiologist, and executive officer. She then transitioned into healthcare quality and performance improvement, holding director and vice president positions for Meridian Health and AmeriHealth Caritas for several years before landing in her current roles of director of clinical informatics for AmeriHealth Caritas and CEO owner of Aperio Statistical Consulting. She has also been an adjunct professor at Des Moines University and Drake University. We are so happy to have Dr. Meghan Shaeffer with us today. Dr. Shaeffer, the floor is yours.
Okay, thank you very much for that introduction. So I am the other Dr. Schaeffer, for those of you who don't know, and your CMO is my husband, but we call him the Dr. Schaeffer who saves lives, and I'm the smart one. So you can laugh to yourselves about that. But thank you again for having me today. I'm really happy to be able to speak on this subject. From the background given, I spent a lot of time in my career studying diseases and outbreaks and situations that nobody ever wants to deal with, including pandemics. And would love to share some of the insights that I've gained over the last 6 months or so with you, and including hopefully some things that you haven't heard before that will help shed light into why this is really critical, actions you need to take right now, and just some considerations to take into account as you move through the community and in your day-to-day. So here's a brief summary of all of the topics we'll be covering today. So we're going to talk a little bit about where this came from. I think it's important for there to be an understanding of where coronavirus came from, why it emerged, where have pandemics come from in the past, and why they might continue to emerge in the future. Some symptoms, which I'm sure most of you are familiar with by now, but just talking a little bit more about, what's the difference between COVID and flu, and how do those symptoms present differently, treatment, prevention, and then, of course, information about the vaccines that are in the queue for hopeful release this fall, and then treatment and some myth busters. So I'd like to start by laying out some common terminology that's common for epidemiologists, and I think are becoming more and more common among everyone else now. I mean, who would have thought that epidemiology was the hot profession, but it is. But these are terms that I'm going to use throughout the presentation that feel free to refer back to or refer back to in the future. Some of the ones I'd like to highlight are isolation and quarantine. Isolation being used in the situation where you have somebody who's sick and who needs to stay away from other folks. Quarantine being someone who's exposed to a case, and we'll talk a lot about what constitutes exposure given the knowledge we have about COVID right now and the need to stay away from other people. And then we'll talk a little bit about trends and data, where to source information, where I was really at, and what resources are good to refer back to when you're trying to track the progression of the pandemic. So this is one of my favorite graphics that I think does a good job of putting this pandemic into context. I think a lot of people were surprised by the use of the word pandemic, about the seriousness of the response. But in actuality, we've had a fair number of completely new to human pathogens over the last 50 years. And it starts way back with dengue, with Lyme disease. I think we all remember West Nile virus and the scourge that affected crows and blue jays and cardinals. But the first time we saw a new coronavirus, which coronaviruses, by the way, are the second most common cause of the common cold, but their first emergence was the SARS outbreak that we saw in China in 2002. That particular strain of the virus was more fatal than what we have for COVID, but it was also very infectious. And the reason why it was caught so quickly is Chinese actually do have fairly good surveillance. It was isolated to a certain area of China and it resulted in very serious and rapid onset of disease. So fortunately, SARS-1 didn't become a pandemic, and neither did its cousin, which emerged 10 years later, which was MERS, and that's Middle Eastern Respiratory Virus. Now, in between those two outbreaks or emergence of new coronaviruses was the H1N1 pandemic. And I think in the beginning, even myself included, we drew a lot of parallels between COVID and the H1N1 pandemic, but in actuality, there are a lot of differences. And I don't think we can really make that comparison anymore, except that the response mechanisms and things that public health and healthcare are using to contain this pandemic are similar. And then lastly, the emergence of COVID-19 almost 10 years after MERS. And just a side note here, that doesn't necessarily mean that we're done with coronaviruses just because we've seen 3 emerging strains in the last 20 years. So where do these things come from? I think the key with this is to remember that these viruses can come from anywhere. Anytime you have a situation where you have a lot of animals interacting with people, especially those that are live and dead, and multiple species of animals interacting with people, you have the potential for those viruses to jump vectors or jump hosts. So in the case of the coronavirus emergence, we know with the first SARS that coronavirus jumped from a bat, which coronaviruses live in bats and can mutate in bats, but don't make bats sick. It jumped to civet cats and then jumped to people via a live animal market in China. Then what we had with MERS was kind of unique, and I think this is a fun example. Maybe fun isn't the right word for that, but you know what I mean. So MERS, again, lived in bats, as did this coronavirus or COVID-19. It spread to camels, but also alpacas, and then to people in the Middle East. And coronaviruses can infect a multitude of different mammals. One thing that we still really don't know, though, is how COVID made the jump from bats to people this time. That's still under investigation, and we haven't really found that intermediary animal species yet. So in terms of the wide scope of pandemics, emerging pathogens, things that have caused pandemics in the past, there are 2 things that are really considered in terms of how we weigh the seriousness of a pandemic. So we look at contagiousness or the reproduction number. You might have heard the term R0. We also look at the deadliness. So if there's a virus or bacteria or pathogen that emerges, but it's highly lethal, it's not as likely to perpetuate itself throughout society depending on how quickly it can kill a person. So with COVID-19, it's kind of in the sweet spot of it spreads readily. It's not entirely lethal compared to some of the other pathogens we've seen, but the key to this pathogen and its success in infecting so many people is the fact that you can spread it 2 days before you have symptoms, or spread it if you have no symptoms at all, and that it has an up to 14-day incubation period, which is extremely long, and that's what's made it so challenging. So how are pandemics identified? So I mentioned why we didn't catch COVID-19 when it first came to be and why we caught some of the other outbreaks. And, you know, to be honest, the one virus that emerges on a regular basis and gives epidemiologists cause for concern is flu. So flu is highly mutagenic. It has a mechanism for replicating in the body that does a messy job of matching up its DNA. So it makes a lot of mistakes, it creates a lot of mutations, and so new viruses constantly emerge from flu. The other thing that's interesting about flu is that it lives in a lot of different species of animals. So it lives in pigs, it lives in birds. And when I worked as an epidemiologist with the state health department, one of my jobs was to run the influenza and respiratory pathogens surveillance program. And it never failed. Every single year, we had the emergence of a completely new flu strain that had never been seen before in people, in a person. Now, typically those strains that were found didn't spread person to person and obviously didn't start a pandemic, but those strains were identified by our state hygienic laboratory, CDC, and then also interacted with WHO. So what I think a lot of people don't know is all viruses and bacteria have some type of genetic coding that can be deciphered and shared, and that genetic coding is called the phylogenetic tree. So we can see the changes in the the genetic sequences of viruses and bacteria, and we can see which ones originated from bats, which was right down here. So the SARS-CoV is the first emergence in 2002. We see a bunch of mutations. We see the emergence of the Middle Eastern respiratory virus, and then we see the emergence of a bunch of different variations of the COVID-19 virus as we know it now. Now, you'll see a lot of different variants here, but what I will say about COVID, it does not mutate nearly to the extent of influenza or even something like HIV. There are mutations where we can see where strains may have originated from, but we're not seeing change substantial enough to affect the treatments that we give people or, to this date, vaccine composition, which is a good thing. So how does COVID-19 spread? I want to address this because I think there's a lot of information and a lot of debate that's changing right now as far as how this virus spreads. So something that is unique to COVID compared to other respiratory viruses are a couple of things. One, the respiratory droplets and the virus are of the size where it can stay somewhat suspended in air for a period of time. We don't yet know, we as in the scientific community, about how long that is or how far it can spread in the air. We know with things like measles, for example, measles can linger in the air for up to 2 hours and is one of the most contagious pathogens known to man. We don't know that time frame for COVID yet, but we know it's possible. We know the most effective way for COVID to spread is person to person. So having a conversation with somebody, even if you're masked, a mask does not mitigate the risk. It does reduce it significantly and definitely protects you and the person who may be infectious, even if that is you. But that person-to-person interaction, especially the longer it lasts, can easily spread that virus. Also from person to surface to person, though this is a little bit less likely. It really takes, honestly, some effort. So it's not a situation where, say somebody is stocking groceries, you pick up a box, maybe they have virus, you put that box in your cart. That situation is not very likely. It would be more something like you get in an elevator after somebody who's actively sick touches a button, you touch the button after they do, and then you touch your face. That's a situation where you might see person to surface to person transmission. So what constitutes exposure? I know we've had a lot of debate in media. We've had some new guidelines released by the governor's office that speak to this, but I'm going to speak to just what CDC lays out and what the science shows. So we know that exposure, approximately 15 minutes within 6 feet of a contagious person, is right for spreading the virus. And we know that wearing a mask reduces your risk by 60 to 80%. And that's if you're wearing a cloth mask appropriately over your nose and mouth that fits your face well. If you're wearing, of course, something more substantial, a surgical mask or a 95, your risk is above 90 or is less than 10%, if not almost zero. But even still, being in that close proximity is still a risk, and CDC still considers it an exposure, even if the parties are wearing masks. So it's not for me to say that the governor's guideline is inaccurate. It doesn't match the science necessarily, but I do understand the logistical challenges of trying to implement quarantine with the amount of disease we have in the population. Some other things to note, that the longer you're around somebody who has COVID, the greater the risk is for you to get sick. And then the other component of this too is to consider where that exposure occurred. You know, if you're in an air maintenance hangar, for example, I work with some transportation companies in Alaska and Washington. They work in these giant rooms where they have some limited interaction with each other. It's well ventilated. That's not a space that's really of concern. It's conference rooms, exam rooms, closed rooms that might not have the best ventilation, where exposures can happen and the risk is heightened even if it's less than 15 minutes. So again, people are infectious or contagious 2 days before they show symptoms through 10 days after. And that window that window stays the same. Even if you're asymptomatic, you start from the date that the test was taken, if you're an asymptomatic positive, through 10 days after. And a negative test does not remove you from isolation or quarantine. So big note there, that does not remove you. You still need to stay in isolation for those 10 days, even if you have a negative test. And you might actually have a positive test after you're feeling better, just because the PCR test cannot differentiate between active infection and ability to spread disease and just having viral particles in your body. So how does it spread? So we've talked about what constitutes close contacts. Now, what situations put you at higher risk for spreading the virus? So I want to really hone in on the fact that we are now seeing widespread disease in some areas of the country and in some Iowa counties where population density is rather small. So this really drills back to the importance of using protection in any congregate situation, even in situations where you might know somebody, but you're just not sure what their actions are. Perfect example, my son takes violin lessons. We do social distancing at his teacher's house, but I wear a mask in the house. He wears a mask in the house, and she does not, because we social distance and she feels comfortable doing so. But I feel like that protection is needed for me, and I need to be the example. So other situations to consider: bars and restaurants, concerts, church, especially if there's any singing that really isn't advised at this time. There are studies that have actually looked at choir practices, one choir practice in particular that was studied by CDC. 62 people were exposed after a 3-hour rehearsal of somebody being symptomatic. Nearly everyone got COVID and 2 people died. So very serious situations, especially when you have people who are vulnerable in a church congregation. Summer camps, I know we're kind of past that point, but sports camps are also applicable. Vacations and travel interactions. It's not necessarily the airplanes. Airplanes have exceptional filtration systems, but interactions in the airports would be where I would be worried. And then, of course, critical situations, anybody who's living in a group situation, whether that's group mental health, prison system, long-term care facilities. Those are definitely very dangerous places. And then even workplaces where you have a large number of employees in close proximity to each other. You have one person who brings the virus into that scenario, and you typically have more than one by the time you're able to detect it, except for maybe a situation like your facility where you have a lot of protections already in place. Symptoms of illness, I think everybody is really familiar with these. The one that's very unique to COVID is the new loss of taste or smell. That is unique. Nausea, vomiting, diarrhea are more common in children, just like flu, but are possible for anyone who has COVID. And then, of course, younger people may only have a few of these symptoms and are not likely to have illness that lasts as long as adults. And I say that's applicable for people who are probably ages 10 or 11 and under, but anyone older than that, all of the literature is pointing to adult-like illness. Here's a symptom comparison chart, and I think this is really, really relevant right now. We have a lot of folks with allergies, a lot of people with cold. We're going to start to see flu in a couple of months, and of course, COVID. So here are the differences in how those symptoms manifest with coronavirus compared to all of these other situations. So we know that there's some crossover with flu and COVID, differentiators being loss of taste or smell, shortness of breath, often cited with COVID patients. And then of course, cough, yes, sometimes diarrhea, GI. So the onset of influenza after exposure is also much quicker than coronavirus. So flu is typically, I'd say 1 to 3 days with a duration of illness, maybe 5 to 7 days. Coronavirus average duration of illness, 10 days to 14, depending on your age and the number of underlying medical conditions you have. So evidence-based risk factors for serious illness. I put these in here really to give you a perspective, a personal perspective to think about, do you fall into any of these risk groups? Does anyone in your family fall into these risk groups? And what protections should you take to be able to avoid serious illness for COVID? So low risk factors doesn't necessarily mean that you are at no risk, but it means there's a slightly elevated risk that hasn't been fully validated in literature. So we do know from some recent studies that type 1 diabetes is probably a condition that actually puts you more in a moderate to high risk group, but the rest have not been studied extensively. Moderate risk factors include things that I think are fairly obvious: hypertension, pregnancy, smoking, use of corticosteroids. But the big ones that we're seeing sustained in literature are obesity, type 2 diabetes, and other serious health conditions. But the obesity one is really key. That is a very common factor seen in patients who are hospitalized. So personal protection, and I know these have all been drilled into us. I think I say the word social distancing at least 20 times a day. We talk about mask usage all the time, but that really is a super critical component of this. But to be honest, I think the most important thing you can do is assessing your risk and taking the actions that you know you need to do to protect yourself and to protect the people in your family and the people you work with and interact with. Yes, social distancing in combination with mask use nearly eliminates the risk of transmission, which is great. We know that aerosolization, though, of the virus could potentially impact that, so we can't say that it 100% protects us, but it nearly completely removes the risk of transmission. Of course, the use of hand sanitizer when your hands are not visibly soiled, washing your hands often, even things like I carry hand sanitizer in my car. After I touch the pump, I sanitize. After I put the pump back, I sanitize. After I use a card reader, I sanitize. After I unload my groceries, I sanitize. So, or wash my hands, whatever I can access readily and quickly before I know I'm going to itch my nose or touch my face. General protection, though, and I know this is, seems kind of basic, but just keeping your basic health needs met, getting sleep, eating well, moving your body, seeking counseling if you're struggling mentally or emotionally. All of those things help support your immune system if and when you encounter coronavirus and have to fight it. So it's important to keep those foundations in place to keep you in your best possible health. So what if you've had COVID? A lot of people have had COVID by now, especially in Iowa. So what do you do if you're sick and you have to stay home, you're worried about what to do? I put some notes in here about what to do if you're in an employer situation. So if you're currently sick, immediately isolate from other people. And by isolate, I mean to the extent possible in your house, you have a dedicated zone that you use. You have a part of the kitchen, you have certain utensils, you have towels, you have a separation of physical space from other people and the ability to clean those surfaces as you move throughout. And remember, you're infectious 2 days before, but then also up to 10 days after you either test positive or you start to have symptoms. Obviously, contacting your own healthcare provider, even if you are a healthcare provider, talking to HR about possible workplace exposures, making sure that you talk to public health to help facilitate contact tracing if needed. And then remember, if you've had COVID, we don't really know how long your antibodies are going to last. So right now, the science is saying you may be protected for up to 3 months, but after that, if you have an exposure to COVID again, you should consider yourself truly exposed and that your immunity might not hold. So when is it safe to be around others? I think we've covered this. I just think this is a really nice graphic to be able to refer back to. So what do you do if you were exposed to a case? Well, there are exposures that sometimes happen in the community where you know you need to quarantine. That may be a conversation you need to have with your HR representative or the leadership in your hospital. Consider whether your exposure constitutes a close contact. Sometimes public health makes that determination for you, or your employer might make that determination too. And then again, quarantine criteria is to stay home for 14 days. And I have to emphasize, and I emphasize this with all of the companies I work with, a negative test does not take you out of quarantine. You can have a negative test one day and then the next day or even hours later test positive. Reason being, PCR tests need a little bit of virus to test positive, but if there isn't quite enough, those tests might not detect it yet. So you're more likely to have a false negative, a false negative than a false positive. And that quarantine period extends from 2 to 14 days following the date of last exposure. So treatment and therapies, there isn't a whole lot we can use, but I will say what we are able to use appears to be making a significant difference in duration of hospitalization and in fatalities that result from hospitalization. So 2 primary treatments, and I'll caveat, I'm not a clinician, so I kept this very basic. Remdesivir, shortening the duration of illness when patients are hospitalized, and dexamethasone, reducing the chance of death with the presence of significant respiratory distress. Convalescent serum, I believe, has emergency use authorization. There is not resounding evidence that convalescent serum works. It's worked in some cases, not others. Randomized controlled trials have not universally shown that it is efficacious, but it does have emergency use authorization. There are no other pharmaceutical treatments that are currently recommended. Now, other things to consider, I consider these sort of adjunctive therapies. A lot of folks believe in, taking vitamin C, vitamin D, zinc. I take several supplements every day to make sure that I maintain that vitamin balance in my body. Especially as you get older, you can have some deficiencies, but that would be a conversation for your healthcare provider to determine appropriateness. So now let's get into a little bit of the data. So the gold standard that I try to use when I'm trying to drive people to resources is try to find something you can digest in 60 seconds or less that won't drive you into a rabbit hole of trying to interpret something, or is this information correct or is it isn't? Is the state providing data? Are they lying to us? In sum, there are several different sources you can go to, but I have thoroughly validated and vetted the state's website, and I believe that their data are transparent. They are not without issue, but they do report cases real time on a constant basis, and those data are reflective of what we're seeing in Iowa. So I put a couple of links here and I'll go through these in just a minute. So the Iowa COVID site, I think, is a nice resource for a couple of reasons. One, it gives you a very quick snapshot of what's going on and you can drill into your county. So Page County, sorry to say, you guys are a little bit out of control right now. There's some significant activity happening, though, I will side note this with, it doesn't take many cases to push you high, but you have had some days with really significant case counts, and that is disconcerting. So this is the time to really double down on those mask strategies, distancing strategies, and consider whether it's really worth it to have an outing, to have a gathering, or attend a gathering unless it's outside in distance. This is definitely getting to be serious, not just in Page County, but definitely in the western part of the state, and I'll show you why in a minute. Other places on the site that I think are useful, if you go to the Regional Medical Coordination Center page within that site, you can get a pictorial of everything that's happening statewide from a hospitalization standpoint and what's specific to your region, or maybe the region you live in if you don't live in Region 4. Something that I want to point out is that yesterday we hit a new milestone. We had 413 patients hospitalized across the state. That is more than we have ever had in the entire period of the pandemic. So Our state is definitely not doing well. Our western part of the state is really driving a lot of this activity, and it is definitely concerning. 61 admissions in the last 24 hours is very significant also. So as far as Region 4 goes, within which Page County is, definitely seeing a drive upwards of hospitalizations. And these data are updated every day. So you can go into the site as much as you like and look at these graphics. So how is Iowa doing? So now we've looked at Page County, we've looked at the region. How is Iowa doing compared to other states? And to be perfectly honest, we are not doing very well, nor have we for some time. So Iowa continues to surge. Here's our first surge. If you look closely back in May, we were able to mitigate that or somewhat dampen the curve. But then as soon as we started to open up in June, we saw an increase within 14 days of cases. We had the 4th of July. We saw a slight reduction, and then we saw a huge surge of cases at the end of August. And that surge was more significant than any we've seen to date. We recovered somewhat, and now we've increased again. So what's been happening with each of these surges, and we're seeing this with a lot of other areas of the country too, is that you first see a couple of counties and metropolitan areas spike, then activity moves on to a different area of the state, new areas surge. This peak here was due in part to colleges resuming session, some schools resuming session. Now a higher percentage of our cases are attributed to kids than they were before. It's 8 to 10% kids. It used to be 6. And now we're seeing really widespread activity, in part driven by long-term care facility outbreaks and mass gatherings in Western Iowa. And these data are all from the New York Times. The New York Times sources their data from IDPH, and they're very transparent about their data. So in terms of our performance compared to other states, we are currently the 6th highest. We have the 6th highest case count per capita in the country. We have been in the top 10 for at least the last 2 months. It's not a place we want to be. The Dakotas are very high, Montana is very high, Wisconsin, Utah, Minnesota has been surging as well. Different factors for this, but again, something I said before that I think is concerning is that these are low population density states for the most part, and they're starting to see surges. We're right in the middle in terms of population density. I think we're number 26 in the country, but we continue to see surges in activity. And so here's what we call a heat map of our activity compared to the rest of the country. So earlier in the summer, we saw huge surges in Texas and Florida and Arizona. Those states implemented very strict mitigation measures, reduced their burden of disease, and they've been able to hold to those, as have other hot spots like Washington, Oregon, San Francisco, and New York. Now, there are pockets of outbreaks in those areas, but so far they've been able to contain the virus. The Midwest is where it's hot right now. And like I said, this is a situation we don't want to be in, and we need to try to pull out of, or we'll continue to see a substantial number of hospitalizations and deaths. And as a side note, in the last 7 days, we had 71 Iowans die, which is more than we've had in any 7-day period since the beginning of the pandemic. So segueing into mortality, I know there's been discussion in the media too about how many deaths is COVID really causing? Well, this graphic shows just on a regular trend basis, this is how many deaths typically occur and how many deaths are attributed in red to pneumonia and influenza-like illness and COVID. So we saw in 2017, 2018, we had a really severe flu season. It was a super cold year. We had a lot of nasty flu. That definitely surged our activity. So these are just deaths as they come in, while we see that COVID had a substantial impact in mortality and continues to affect mortality as we move through the pandemic. The country as a whole is still struggling to maintain virus. So this surge here was driven more by the states that I mentioned, the Florida, Texas, Arizona outbreaks. Now the Midwest is driving the inability for us to drive down total cases as a country. And this is how the United States looks in terms of a worldview. We are as red hot as it gets, with the exception of maybe Spain and France, who are now surging. We've been in a red state for a very long time, Brazil has also been in a red state for a very long time. Some of these other countries in Europe were able to contain the outbreak, or sorry, the pandemic, and they do struggle with periodic outbreaks, as we may see surge this fall. Okay, so let's switch gears and talk about the vaccine. So I want to just note that the vaccine, while this is absolutely lightning speed, and it really is phenomenal, the fastest the vaccine that has ever been developed in humankind was mumps, and it took 4 years. But according to all the reports, FDA, White House, and the manufacturers themselves, 2 vaccinations, one made by Pfizer, one made by Moderna, may be available sometime this fall. We do not yet have a date. We do not yet know how many doses, and we do not yet know what the research will show in terms of vaccine efficacy. So there are a couple of challenges to trying to create a vaccine in warp speed, not just from a manufacturing standpoint, but from a how will this actually protect our population standpoint. So a vaccine is just one of the tools that public health will have in their toolbox. Once we even have the vaccine, we're going to have to continue mitigation efforts in our communities to keep this under control and keep people from being hospitalized and dying. Some of the challenges in trying to put together these studies really quickly are that typically vaccine studies will look at 2 different things. They'll look to see if a person elicits an immune response, but they'll also look to see if there are side effects. And then they'll look to see that when challenged by that pathogen, does the person develop illness? That second part is what we are not able to measure in time for release of this vaccine. So we will have limited data on whether or not the vaccine truly protects against the virus. We will, though, have evidence about its safety and about its ability to promote an immune response. So those are good things. The positive things I'll say about the vaccine are that Moderna in particular had already had a phase 3 clinical trial of a MERS vaccine, which is very similar to COVID. And actually the construct for the vaccine for COVID is very, very similar to MERS. It's the same mechanism. So we know that that type of vaccine has been studied for 8 years, which is great. And the reason why Pfizer is also in line with Moderna in terms of developing this is because Moderna did not patent all of their technology. Pfizer took it. Pfizer has developed a very similar exact mechanism vaccine to Moderna. So that's the premise for the vaccine. What it does is it puts some viral particles into your body that can't make you sick, but it does make the warriors in your body, or your body's immune response create antibodies to those particles. So it can elicit a response. Will it be safe? Yes, like I said before, we will have a chance to have studied the efficacy and the safety for the most part with some of these large trials. It is really similar to MERS. It will likely only cause maybe mild reactions, even less so than flu. And some of these studies are really large, 30, 40,000 people. So I think those all give us at least enough consolation that they've been thoroughly evaluated. I think the question lies more around efficacy. So what's going to happen as we approach fall and we have flu come and we have schools back in session, but then it starts to get cold? So epidemiologists typically consider the fall and winter respiratory virus season, and I'm sure healthcare providers do too. So we see a myriad of respiratory diseases in the fall and winter. We see adenovirus, parainfluenza, RSV, and then around the 3rd week of December, we start to see flu, and we already have COVID. So we are still in, though, really the 2nd or 3rd, I guess this is technically the 3rd peak in the first wave. So a wave of a pandemic typically is considered closed. When we reach a level of community containment, we have not gotten to that point yet. And we still know that only a small percentage of the population has actually had disease and may have immunity, 10 to 20%. So there are plenty of susceptible people for COVID to infect. So what's likely to happen this fall? There are a lot of different scenarios that could play out. We do know that co-infection with respiratory viruses and COVID is very visible and could very severely and significantly affect many people. However, some of the things that we've seen in other countries, so the Southern Hemisphere having already had their winter and also had COVID, like Australia, South America, some of the mitigation strategies that they use to protect against COVID will also prevent the spread of these respiratory viruses. So, if anything, using those protections and continuing to do so even with the release of a vaccine and all the way throughout respiratory virus season are absolutely imperative. If we do those things, in addition to flu vaccination, that could really reduce the potential for co-infections with other respiratory pathogens. What about beyond respiratory season? You know, there's been a lot of speculation as to when a vaccine will be widely available. In realistic terms, it's probably going to take a good year, maybe 18 months, before there's widespread usage of the vaccine. But another thing that I think is cautiously optimistic is that there are other vaccines that are in development that may be even better than these first rounds of vaccines. The first rounds have been pushed to provide some efficacy, but some of the future vaccines may be even stronger and able to cover a broader spectrum of coronaviruses that could even help prevent things like the common cold that's attributed to COVID. This is just a graphic for those of you who are maybe data nerd oriented that shows which flu strains have been dominant the last couple of years. You know, it used to be more than 10 years ago before the pandemic that we would see a seasonal B surge that was a little bit later than A. But in the last several years, including the really severe year in 2017 and 18, the two have overlapped. And we've seen quite a bit of A, H1N1 variant, which is a mutated strain from the 2009 pandemic, H3N2 influenza, and then a fair amount of B that have all affected our populations. But one thing that I think is fascinating about this graphic is that we usually see flu in very close alignment with dips in temperature. So the yellow in the background is the average daily temperature for Iowa, and then the spikes are flu activity. So we can pretty much count on the dip in weather, and then a spike in flu a couple days after, if not a week or two. Okay, top 10 reasons for wearing a mask. Throwing this in here if you're not yet convinced at how important this is. As you all know, masks protect you, but they also protect other people. You also protect people who might not be able to wear a mask. COVID, and more literature is emerging about this, can have significant long-lasting effects on people. And we have some people who've had not just 30, 40 days of illness, but they have chronic fatigue. They have long-lasting heart issues, immune compromise, or inflammatory responses that sustain long after their infection has resolved. We know that COVID-19 is incredibly lethal to the elderly, and our long-term care facilities have already been on lockdown for a really long time, but they are going to be even more vulnerable this fall, and so the protection of them is even more paramount. Healthcare capacity is also at risk for being exceeded this winter if we don't develop stringent mitigation efforts and we have serious outbreaks of influenza or other respiratory viruses. Masks are simple. It's just a piece of cloth. It's just when you're in public and around other people, though I will say, if you have infection and you're trying to isolate at home, you may want to consider mask use at home too, or if you're quarantining and you know you've had an exposure. It sets a good example. I am so appreciative whenever I go into a gas station, whenever I go to the grocery store, which is not very often, of people who really take that action. And I know it seems like something that, oh, it's a pain, I don't like to wear them, it's an infringement on my rights. You know what, it's just a piece of cloth. And you put it over your face for a short period of time. But I think particularly those who work in the healthcare field like all of you do, you're the example. And people look to you to set the example. And it's really important for you to take note of that. Reducing the spread of COVID-19 in your community is going to be paramount. As I showed in Page County, this is a problem, and in Western Iowa too. It's better than wearing an N95, as I know a lot of you have to in different situations in your hospital. And lastly, it's not forever. This is not going to last forever. I promise. It's not. We will get through this. But in the interim, if you can take that action, you are going to save lives. So in closing, I have a couple of mythbusters. These are supposed to be fun, but they are actual questions that I received either from friends or family or the other Dr. Schaeffer has received. It's a bacteria. Nope, we know it's a virus. There's microscopic evidence of that, and it has a different mechanism of infection, the bacteria. We all need herd immunity. I think the fact that Iowa has had so many deaths and so many deaths recently is really alarming. I've had a family member die from COVID. There was a West Des Moines staff member, school staff member who died yesterday. There was a 23-year-old in North Carolina who died. So this is really starting to spread its fingers into all facets of society, and we don't want to just let it run rampant. And we would need to infect 20 to 80% of our population, which would mean we'd need at least 5 more waves of the pandemic to get to a point of herd immunity, and we don't even know how long that immunity will last. Hydroxychloroquine, I think we all know, especially in the medical community, that the efficacy was just not there. There were some observational studies that showed effectiveness, some with or without azithromycin, but when randomized clinical trials were performed, the evidence did not support the use of hydroxychloroquine, and actually the side effects of using that medication in a lot of people was enough to stop the studies. Children cannot spread the virus. So there are more and more studies coming out that, as I said before, talk about kids under the age of 10 or so that can spread the virus well, may not get as sick as people, or may just be asymptomatic carriers, but children and adolescents ages 10 to 19, 10 to 17, that junior high school range, are having infection and hospitalization rates similar to adults. They have not been exposed to the extent of adults because most of them have not been in school until recently. But that is a population we have to be very careful to protect. China made the virus. So I showed the phylogenetic tree. Fortunately, people are not smart enough to make a new virus, which is a good thing. People have been able to modify viruses to the point of just the packaging of it, so we can basically weaponize pathogens, but we don't know how viruses infect people or how to change that to make them infect people. We know this virus lives in bats. We don't yet know how it made the jump to people, but we have a lot of genetic evidence that shows that this evolved naturally. And then drink bleach, of course, let's not. I think we all know that. Social media made this up. There are still some naysayers out there who just feel like this is all a farce. I think all of you know that it's definitely real. This one is interesting, and I've actually heard this a ton. I probably hear this once a week, that I had this really severe illness in February, and I went to Florida, and I know I had it. Well, you know what? Even if you did, you probably don't have immunity anymore, and it's probably not likely. So CDC has gone back and tested flu specimens, which, as many of you know, is basically the same as COVID specimen. And they've tested it for COVID, and they really didn't find any evidence of earlier spread, maybe low levels in areas of California and Washington, but nothing to support the virus was here before we actually have said it is, or was. Case counts include confirmed and probable cases. That is not the case in Iowa. Iowa includes antigen, or rapid test positives, and PCR positives. There is an epidemiologic practice that if somebody has the symptoms of illness and an exposure to a confirmed case, they would be considered quote unquote probable, but Iowa is not reporting those cases as of now. And lastly, alcohol kills everything. Strong microbial cleaners kill everything. Alcohol that you drink or that you just put on surfaces, yes, as long as it's microbial concentration, can kill the virus. But this is more specific to outbreaks that I've worked in the past among college kids who think that because they're, passing a beer or, playing a drinking game, that alcohol is going to take care of it. And that's not necessarily the case. So lastly, I put a whole bunch of references in here. Everything that I have in the presentation, I have some literature citation for. Feel free to explore these. Feel free to explore all the links that I put up as far as where to get case counts, where to get evidence, and how to follow the progression of the pandemic. And that is all I have. I'm happy to take any questions in the time we have left.
Again, if you guys have any questions out there, go ahead and use the chat feature and chat those to me.
And I'll say again too, sometimes when I interact with groups, there are some personal questions that people want to ask that they don't want to ask in front of a whole group. So if you do, feel free to contact Renee or the other Dr. Schaeffer or me directly. Be happy to answer those questions in private.
So we do have a question about reliability of information. So the question was, usually the first place we go for information or answers is government sources. And it at least seems like some of that information is being changed, modified, or watered down, at least in the media. So where do we find reliable information that we can have confidence in?
It's a great question, really great question. It's a difficult one to ask. So with some of the guidance that's come down from IDPH and the governor's office, I research, first of all, any sources that they may have cited in their release of guidance, most of which I've found are not necessarily supportive of the changes in guidance or the stance on inaction. So I'll say that, trying to be as apolitical as I can. Now, what I am seeing from CDC, though, is fairly consistent. CDC is always conservative in changing their guidelines. They like to have copious evidence before they make a change. But in general, when they put out guidelines, what I like about being able to go to CDC's site is that there are articles that you can pull up to see the studies that they use to create those guidelines. Now, there have definitely been debates about things like changes in testing guidelines. I think CDC has changed the course back on that. They are now adding the evidence of aerosolization to their transmission protocols, which the World Health Organization has been pushing for the United States to adopt for a long time. But again, all of those are evidenced in articles. So I use CDC as my main source of information. And even when I see things in New York Times or CNN or Fox News, and I review all of those sites through Google News on a regular basis, I still look at the article because you have a lot of lay people trying to do what I'd call sort of layperson epidemiology and trying to interpret those studies. So going to the studies themselves, reading the summary of results, everything is open source right now and you can do that. So I think if it's a critical point of decision making, going to CDC, reviewing the evidence that supports CDC, and then making that informed decision is the best way to go. I see we have a question about immunity, and that, this is Dr. Darwikar, that's a great question. So far so good, that's great. There is evidence antibodies can extend past 3 months, and severity of illness does affect how long the immunity lasts. What we don't really know yet are the role of T helper cells. So that's your super sustained immunity. Right now, we've just been able to look at IgG, IgM, and how those antibodies are responding in terms of their concentration. So as long as you have evidence of IgG antibodies, you should have some protection. As those start to wane, though, it is possible your T helper cells could be taking over some of that if you get a re-exposure. But right now, we just don't know the solid answer to that. So yes, 3 months is the average, but it's not the end-all be-all. Thank you for the question.
Okay. Well, I don't see any further questions. If you guys have those later, come up with additional questions, please let me know or let Dr. Shaeffer know. We'll be happy to get those answers for you. Thank you, everyone, for participating today. Thank
Thank
you,
you so much.
Dr. Shaeffer, for doing this for us.
You're welcome. Anytime.